My name is Tanya Baban.
I'm Amir Nofal.
Hello, my name is Muhammad Omar.
Hello, my name is Gustavo Rangel.
Hola, mi nombre es Carla González.
I'm Lilia Kuri.
Assalamu alaikum. This is Dr. Farhana.
السلام عليكم. معكم الدكتور امتداد حسين عبد الله الوهاشي.
أنا عبد الرحمن الأطرش.
We're always there. MedGlobal doesn't wait for disaster to strike. Since 2017, we've been on the ground, responding to crises within hours.
We are offering a life-saving healthcare, essential medical aid, and fighting against food insecurity.
Bringing hope and essential care to those who need them most.
For me,
this is not only a job, it's personal.
I have joined MedGlobal organization in Gaza. That's because of several causes. The main of them that it's a humanitarian organization and due to a very huge role in saving our children here.
اخترت العمل بمنظمة ميدي جلوبال لأني بتمثل إلي فرصة فريدة لأنه أجمع بين التميز المهني والمساهمة المجتمعية. ميدي جلوبال مو مجرد منظمة عمل بل هي بيئة بتحفزني على تقديم أفضل ما لدي والتعلم من تجارب الآخرين.
I'm working with MediGlobal due to its unwavering commitment to improve the healthcare access for the underserved population. Knowing that our efforts make a tangible difference in people's lives and in nutrition and health, it's incredibly fulfilling, making every challenge meaningful.
I've seen firsthand the impact we have on families who've lost everything, changing their lives in ways that matter.
But MedGlobal is also about planning for the future. We're not just responders, we are builders.
We start projects that continue long after the immediate crisis has passed.
Our work is designed to provide sustainable solutions, ensuring that communities are supported both during and after disasters.
We also empower local medical staff, training them to become trainers themselves. One trained professional becomes 10, and 10 become 100.
Through partnerships with local governments and local partners, we create programs that save lives.
And will continue to do so for generations to come.
None of this would be possible without your support.
Every donation,
every contribution
allows us to provide critical care
to those in the greatest need. Together, we're making a real lasting difference in the world.
Assalamu alaikum wa rahmatullah. I'm really humbled to be among you, and this is an amazing crowd, and I really enjoyed the presentation before me, and you made my presentation much easier, Brother Yusuf. And so I'm just gonna maybe follow on some of the aspects that you've mentioned. And I don't know, was that coincidental that you had your presentation before mine? Because basically my presentation is the application of what we need to do as physicians, as healthcare providers, as humanitarians to reduce some of the racism which is now manifested itself in inequities and especially healthcare inequities throughout the world and also in our country. I was speaking with Ali, where's Ali? Here, emergency room physician in Trenton, right, in New Jersey. And he was telling me that he works in two hospitals. One of them is an inner city hospital, and the other one is more of tertiary center. Similar to myself, I work in Chicago in two hospitals. One of them belonged to one of the largest healthcare systems called Christ Advocate Medical Center. And the other one is a safety network hospital where I met one of your members, Dr. Dahadwala, who introduced me to the community. By the way, I'm very close to your masjid in Willowbrook in Chicago, 5 minutes away. So every day I pass by the masjid, and I was invited multiple times. I attended a few years ago the birthday of Imam Sayyidina Burhanuddin also. And many of my neighbors, patients, and colleagues are from your community, and I'm really honored to be among you speaking. And I'm the least person, probably qualified person to speak about this topic. Many of you have been doing this, but I'm honored to be here. So I work in 2 hospitals. One of them is San Anthony's Hospital, Safety Network Hospital. The life expectancy in that area in Chicago, and Chicago is a very segregated city, as you know, is 10 years less than the other hospital where I work in the neighborhood. So in Chicago, if you happen to be born in a certain zip code, that will determine your future and your access to health care. And this is something that as physicians, we don't talk about that much. We just practice and we serve our patient, which is very noble. But I think we should lead as a Muslim community in talking about these issues that affecting our neighbors. And I think this is the essence of our faith, if we're talking about our faith. And I'm not going to quote many of the ayahs in the Quran and the hadith of the Prophet and the hadith of Imam Hussein and others, disciples of the Prophet, that talk about the fact that the essence of our faith is to help the most disadvantaged. And if you just go to the mosque and pray and fast and give zakah, it's good. But if you do not translate these rituals in helping the most in need, then there's a problem with your faith. So that's kind of the essence or the idea of behind forming MedGlobal. The mission of MedGlobal is to reduce healthcare inequities in the world, which I believe that this is also a unifying message. I flew last night from Salt Lake City, and you can say, well, I mean, I'm from Chicago, why would you go to Salt Lake City? We have a partner in our global health work, is the LDS Church, Latter-day Saints Church. And I met with their second leader, President Dallin Oaks, yesterday, very accomplished person. He's 93 years old, and he lives by the tenet of his faith. And I asked him about what his advice for me and through MedGlobal. The Latter-day Saints Church supports some of our programs in Yemen, in Syria, in Sudan, in Bangladesh, and other places. And he said, first of all, this is a political season, of course. I think we just finished a very polarizing election. I hope that our country and our community is not affected by what to come, but we need to be ready. He said, stay above politics. That means your organization should be working with all parties, and it should not be really affecting your community if you just support one party, and don't support the other. So work with both parties. And the second thing he said, talk with other partners about what is uniting us. What are the common things that unite us? And I thought that especially the second tenet is very important, because sometimes we look at the differences and we don't talk about what unites us. And there's a lot of things what unite us. You've mentioned, Brother Yusuf, racism. And I think there's a lot of racism within the Muslim community also. Not only for the African American community who opened the doors for us to come to this country because of the civil rights movement, but also South Asians against Arabs, Arabs against South Asians, Syrians against Egyptians, Palestinians against others, Sunnis against Shia, and vice versa. And we have to tackle these issues. We don't talk about these issues within the Muslim community, and I think your speech should be part of our Friday sermons, that every masjid should be talking about racism within the Muslim community, because it is there. So my topic today, and I hope that we can be engaged in this topic, is how to administer healthcare in complex humanitarian emergencies. And I'll highlight in the second part of the presentation some of our work in Gaza. I don't have any financial disclosure, but you're welcome to donate to MedGlobal. We do life-saving work, and these are some of the learning objectives. And I think when Brother Yusuf Zakir was mentioning about the biases, in the humanitarian world, there are biases. You know, although many people have this noble intention to go and help, but also some of the practices that we witness in this type of work, there is some prejudice and bias and racism. One of this main prejudice is something related to colonization. When you think of an organization that sends doctors and nurses to disaster regions, what comes to your mind? What's the name of the organization? Doctors Without Borders. Doctors Without Borders was established in 1970. One of its co-founders, Dr. Jacques Berry, actually joined us in Yemen in one of our missions, and also in Bangladesh. And he was telling me about the history of Doctors Without Borders. It's a group of French doctors and humanitarians who responded to the civil war at that time in Nigeria, and they established the NGO. And the premise behind it that we want to go and help. And we know what is better for the population in Nigeria or in Bangladesh or in Pakistan or in Syria or in other places. So this mindset that doctors in the West know what is better for communities that are going through disaster is part of this colonization heritage. MSF is doing a lot of good work, and I think they changed over the years and they evolved, but this mindset that a doctor from the US will go to Gaza to help the people of Gaza because they are in need for her or for him is part of this colonization mindset, and that we know what is better for this community in Gaza more than the local doctors and nurses, and this is something that we need to fight. I like the poetry or the poem that Brother Yusuf mentioned, وَلَا تستعمر. This idea of istimar, colonization, is part of the heritage of global health. Disregard to local communities. Local communities are the best one equipped to provide solutions to the problem that they are doing. What are their healthcare priorities? What are their needs? What kind of technology that works in Gaza or in Syria or in Pakistan or in Yemen? This is something that the local community are more equipped to provide us with solution than us coming from the West to provide help them. Medical missions by itself is something that we need to think of as a distracting to the local community. And although we do medical missions, I've been in 50 medical missions, and many of you have been in medical missions, but this is not the best way to address healthcare disparity in disaster areas. The best thing is, as I've mentioned here, is providing training to doctors and nurses and midwives in disaster areas. And as you've seen in the videos, most of the local health programs that we have are provided by local doctors and nurses and midwives and mental health specialists, but we need to equip them with training, salaries, advocacy, and other things. And the other thing that we need to be aware of, and this is something goes to Nia, to your intention, is don't go to places in disaster and expect that you come back and you will be received as a hero. And there is this reality of people who are going to these places and then coming back, and they put now with the social media that I've been in Gaza, I've been in Syria, I've been in Sudan, and then they want to be given likes and they want to speak on TV and they think that they are the heroes because they've been there. And this is not the right case. So we have always to question our intention. Why are you going there? Are you going there for the right intention? And what would be the best way for you to help the population? And question also after you come back why I'm saying or doing what I'm doing. And this is a drawing from a second grade student child in Syria. And during the peak of the Syrian crisis, I was involved in several missions, and I was at that time the head of the Syrian American Medical Society, and we've witnessed the impact of the war on the population. And this is the drawing of the war in the eyes of a child. And you can see the grief, you can see the pain, you can see the bombs, you can see the fire, you can see the mutilated children. What is heartbreaking in this picture that the children who are dead are smiling, and the children who are alive are crying. And I've seen that over and over in Gaza and Yemen and other places. Some of the challenges that we face in global health, especially when you work in complex emergencies, attacks on healthcare, that became a reality. Actually, after this conference, I'm going to be leaving to Qatar. There is a world conference on innovations in healthcare, and one of the panels is attacks on healthcare. We have a report about it's becoming a common phenomena. You hear every day attacks on this hospital, Kamal Udwan Hospital in Gaza, attacks on hospitals in Syria, in Ukraine, in Sudan, and other places, and it became normalized. And as you know, part of our heritage is to respect medical neutrality. That means even in the time of the war, we should not be attacking civilians, we should not be attacking nurses or doctors. We all have stories about in the Islamic history where you have a Muslim leader or a Muslim doctor that treated the enemies. And the Geneva Convention 150 years ago came to reinforce these ideas of medical neutralities and impartialities. That means even in the time of war, you are supposed to be, as a doctor and as a nurse, to be protected, even if you are providing healthcare to the enemies, to the injured enemies. And this is not happening. Every day you have attacks on hospitals and on ambulances, on doctors and humanitarians. In Gaza alone, according to the World Health Organization, more than 1,200 attacks on healthcare in the last year. that killed more than 700 doctors and nurses. So imagine how long it will take to replace those doctors, some of them very senior, and surgeons who were killed in Gaza alone, which is a small area in very confined place. Mass casualties even. I'm going to mention some of the stories that we've witnessed about mass casualties. When your system is overwhelmed by the number of the casualties that come to you, so even during the time of peace that you can save some of these children or injured people, you're not able to save them during mass casualty events. So what kind of training that we need to do to prepare communities for that? Shortage of food and clean water, electricity, and communication that became now a norm of war, that you deprive communities from water, clean water, that will lead to more outbreaks, hepatitis, polio, and many other waterborne diseases. Electricity, communication that are much needed for transportation and the supply chain and everything else, and food. And that's why we're seeing malnutrition and famine in Gaza and many other places like in Sudan. Limited resources. One of the best things that I get out of my medical missions, and I tell my colleagues who want to go to medical missions that you will be a better person if you come back, if you have the right intention. And also you become a better doctor and nurse because you will know how to deal with limited resources. And you can say, well, why do we have to learn these skills in the United States? I mean, we have abundance of resources. Can you give me an example of a recent example that we had very limited resources and a lot of patients? COVID pandemic. So when you go to these areas and you see the solutions that the local communities are providing to deal with these influx of large number of patients, then you will come back here and you can deal with disasters that we're not immune from, like the COVID pandemic. I remember the plastic bag that I was given, especially in the first few weeks of COVID pandemic, to put my PPE, a mask, in it, and I keep it for 1 week because we did not have enough PPEs, if you remember, in the United States of America. Displacement of the population, which is a major thing in Gaza. Many of the communities, 90% of the population in Gaza, for example, are displaced. 11 million people in Sudan right now are displaced. In Syria, half of the population have been displaced. And displacement, that means you are disconnected from your communities, from your mosque, from your leaders, from your clinics. So even if you have simple disease like hypertension and diabetes, you will not have access to your medications, and we need to deal with this situation. You have areas under siege right now. North Gaza is under siege. The 3 hospitals in North Gaza, Al-Auda and Indonesian hospital in Kamal Udwan, are not functioning. That means you have 400,000 people without access to health care, and it is inaccessible, even if you're trying to help them. So how do you deal with a situation like this? Non-communicable diseases. Always when we talk about emergencies and disasters and wars, we think of injuries related to the bombs and missiles and crush injuries, which is reality, of course. But many patients die because of the lack of medications for heart disease or for COPD or asthma or cancer, and they're not in the news. So in the context of Gaza, more than 43,000 people were killed. More than 16,000 children were killed, but we're not hearing about the thousands of people who are dying because of lack of access to dialysis or to chemotherapy, which happens in Gaza every day. Outbreaks related to the lack of clean water. And that's why our organization not only provide medications and medical supplies and training and medical technology to doctors, but also we try to provide clean waters, because without clean water you will have outbreak that may also kill a lot of people. And then the mental health trauma. I mean, every person in Gaza, every person in Syria at one stage, every person in Sudan, every person in disaster area have mental health trauma. And these are compounded mental health trauma, especially in the context of Palestine, because it's been going on for generations. So you have the first generation who's affected by displacement, and then you have the previous generation, and now you have the new generation that is affected by the displacement and the war. So it becomes part of the DNA of a Palestinian to have a mental health trauma, and it's very difficult to treat. And then disruption of training and education. We don't think about medical schools. Every medical school and university in Gaza has been bombed. So every medical student and a person in training is not getting proper training right now in Gaza for the last year at least. And many of them are thinking of leaving Gaza. So war does not only affect patients, but also affects education and training. These are some of the principles of how to deal with limited resources. I spent 2 hours in one course about talking about these principles, how to prepare for a disaster. And I think this is something that we have to talk about it in our communities, how to prepare for disaster, how do you conserve during the disaster, so that way the limited medications or the oxygen or the ventilators or the dialysis units that you have can serve many more patients. How do you substitute, for example, if you don't have enough morphine, how do you give codeine? How do you give, if you don't have certain anesthesia medication, how do you replace that? How do you adapt to displacement, and how do you adapt to bombing of your hospitals? I work in hospitals. I'm going to show you some pictures that are built underground or in caves in Syria because the community wanted to adapt on the attacks on healthcare. How do you reuse certain things like the PPEs during COVID pandemic, and how do you reallocate? So these principles of dealing with limited resources, although they're not part of our medical school training, but they're important principles that when we deal with disasters. This is Dr. John Kaler. He's one of the co-founders of MedGlobal. He's a pediatrician from Chicago. And this is a picture of him treating one of the patients in Gaza. Her name is Alma. She's 5 years old. She was displaced from Gaza city to Rafah. She's living in one small room with 16 other people, and she does not have clean water. And she came in with bloody diarrhea. Her mom told me that every night, and you know, I was there in Gaza in January for 2 weeks, and every night you will hear bombs. And actually the war is very close to you because we were staying in Rafah and the war was in Khan Yunis. So you open the window in the morning and you see the missiles and you see the fighter jets and you see the drones and so forth. And at night it's bombing after bombing after bombing. And she told me that every time Alma hears the bomb, she goes to her mom's bed and she's shaking and she's crying because of the bomb. But she came in with bloody diarrhea because of lack of clean water. And the solution is very simple. Oral hydration fluid, and they were not available in Gaza. This is a hospital that was established in Syria because of the attacks on healthcare. It's called the Central Cave Hospital in Syria, north of Hama. Because the local community refused for the doctors to build the hospital in the village because it was bombed previously. So the doctors built it inside a cave. And if you're inside the hospital, actually, and you don't look at the ceiling, you think that you're in a real hospital. You have monitors, you have ventilators. The director of the hospital is a cardiologist, but this is how it looks in the outside. This is a cave inside a mountain. And that gives you an idea about how important for the local communities to have health care during the disasters, because without hospitals, people leave. I talked with people in Gaza and Syria about the importance of access to health care during wars. And they told me that they can tolerate the bombs and the missiles, but if there's no doctors in town, there's no nurses in town, people leave. And that's why we have right now a crisis of displacement. 125 million people are displaced, 26 million refugees, because when you have no access to healthcare, people just leave. Technology can be used in the war, and part of the things that we started in Gaza, by the way, we don't believe in parachuting in and parachuting out. We don't just send doctors during the war and then forget the community. We believe in sustainability. This is also part of our religion, Sadaqah Jariyah. That means you do things that will last for a long time. Most of these communities affected by disasters will have disaster after disaster because of climate change, because of displacement, because of poor governance, because of wars. And so it's important to stay with these communities for a long time. So we started in Gaza in 2019 by providing training to doctors in emergency room and critical care units with the POCUS training, portable ultrasound training. And I'm happy that you have also some portable ultrasound training during the conference. So this is for those who are not in the medical field. This is a probe that you connect to your iPhone or your iPad, and your iPhone or iPad becomes a Doppler screen. So you can put the probe on your chest in the injured patient to see if there's a collection of air or collection of blood. So you can put a chest tube, you can put the probe on the heart to see how's the heart function, or you can put the probe on the belly to see if you have bleeding inside the abdomen, so that way you need to send the patient to the OR. So you can make a decision at the bedside. That's why it's called point-of-care ultrasound. That will make the difference between life and death to your patients. So we did this training of trainer in 2019, and then every 3 months we used to send what we call it resiliency medical mission. So it's not the typical medical missions where you have surgeons who go and provide surgery. Sometimes it's important, but this is focused on training. And every time we donate multiple ultrasound to the hospitals, Al-Shifa Hospital, Nasser Hospital, and many other hospitals. This time when I was in Gaza, every emergency room physician, every critical care specialist is using portable ultrasound. Because they don't have access to MRI or CT scans, it's very easy, it's adaptable. So using technology in disasters help, but technology should be cheap, should be adaptable, should not require access to electricity, so it needs to have a battery. And this is why portable ultrasound is one of those technologies that can democratize medicine, improve access to healthcare. So I encourage every one of you, especially if you're interested to work in area with limited resources, or you participate in medical missions with MediGlobal or other organization, to learn the skill on not only how to do portable ultrasound, but how to train on portable ultrasound. There are many other technologies that can be used in disaster area. Some of them is telehealth. This is very simple. When you don't have access to communities, you can do very simple things in these communities. Some of them are as easy as having a WhatsApp group or any other platform where you have a group of physicians on the other side in Yemen or in Sudan or Bangladesh with a group of physicians here. And the physicians on the other side can send pictures and videos of their patients, and the physicians in the United States can provide them with consultation. And it can be back and forth. So this is a very easy way, and we've done it in Syria, where we had ICU, ICU groups of physicians from Syria and physicians from the United States. But the sky the limit in telehealth, and this is in a way that you can provide access to healthcare even if you're not physically present there. This is one example of these ultrasound ICU WhatsApp groups. There's other ways that an innovation, you can help the population using water purifications in hospitals that are dependent on clean energy, solar energy, because many times in areas you don't have fuel even. In Gaza there is shortage of fuel. So how can you use clean energy, portable mobile generators in some areas because there is no electricity. This is an innovation in Syria where the local community used cow waste to produce methane gas for renewable energy because they did not have access to electricity. And also how to amplify the waveform for communication, because lack of communication is one of the major obstacles to communicate with local communities. And without communication, many bad things happen. These are some of the future direction that we need to deal with in global health. How to reinforce international humanitarian law so doctors and nurses in disaster areas feel secured, so they're not bombed, they're not killed, and their hospitals are the same thing. Without accountability, there will be impunity, and that's what we're seeing right now. So not only doctors who should be more vocal about these issues, but lawyers and human rights organizations and policymakers should be dealing with the situation. How can we collaborate and partner together? You cannot do everything on your own. No matter how big is your organization, you need to work with other NGOs, with local communities, with policymakers, with the UN to improve access to healthcare. The idea of decolonization, and this is very important, and how can we transform this global health paradigm that is based on the West helping the global South. And also how to improve data collection and analysis so that way we can do things right. We believe in evidence-based medicine in the United States, but how can we practice evidence-based medicine in the global health? Measuring our impact, visualizing our impact. Nowadays, we are in the age of social media. So you cannot just talk about what you do, but you need to provide videos, you need to provide pictures, and that way people know what you do, so they can amplify your message and they can collaborate and improve it. The role of AI and VR, I think there's a lot of things that we can think about, innovations that can improve access to healthcare and reduce healthcare disparity in the future. I'm going to focus in the last part of my presentation about one of our resiliency medical mission in Gaza. And this is the geography of Gaza. As you know, it's a small strip, 25-mile length and 6 miles in width, bordered by Egypt and Israel. So there's only one axis in the north, one axis in the south. So when we were in this medical mission, last medical mission, I've been in Gaza 4 times. The last one was in January. We went to Cairo, and from Cairo we drove to Al Arish, about 16 hours. And then from there we crossed to Gaza through Rafah border crossing. Right now Rafah border crossing is closed. So the only access to Gaza is through Karam Abu Salim border crossing. That means you have to go to Jordan, from Jordan to Israel, and from Israel to Gaza, and it's very limited. We just had our last medical mission leaving a week ago. We had 4 physicians from the United States, including anesthesiologists and surgeons and pediatrician, and they stayed in Gaza for 4 weeks. And we sent so far during this war 6 medical missions. But all of our programs are administered by local doctors and nurses. We have 19 medical points and 3 stabilization units for the treatment of malnutrition that provide health care every day for 5,000 patients every day by local physicians. We provide them with training, salaries, advocacy, medical supplies, and medications. And they provide primary health care, treatment for infectious diseases, prenatal care for pregnant women, mental health support, and wound care to the local populations who are themselves displaced. And this is the geography of Gaza. 70% of Palestinians in Gaza are descendants of refugees who came to Gaza from 1948 and 1967. And sometimes they see their villages on the other side, but they cannot, of course, cross the fence. This is our team. We had 5 physicians, Dr. John Kaler, Dr. Nahreen Ahmad, she's a critical care specialist from Philadelphia, Dr. Thaar Ahmad, who's Palestinian doctor, also is emergency room physician from Chicago, and Dr. Chandra Hassan, who is a surgeon from Chicago also. And in our way to Gaza, we've seen thousands of trucks on the Egyptian border that are not allowed to cross to Gaza. So even though that we're talking about increasing aid for a year, but there's a lot of aid that is outside of Gaza, is prohibited from getting into Gaza. We're talking about food, we're talking about tents, we're talking about medications, medical supplies, personal hygiene units. There's like shortage of everything inside Gaza because of the war. And this, by the way, this is my video. When I go to medical missions, I try to document what I see. I take videos, I take pictures, I write the names of people because it's important to put names behind the pictures and the numbers. Numbers do not move people to action, but names and pictures and videos move people to action. And this is inside Gaza. When you enter Gaza, you see tents everywhere. And these are not proper tents, these are tents from plastics, ragtag things that will not protect you from the elements. And this is the fence, the border between Gaza and Egypt. It's impossible for any person to leave Gaza, even if you want to. And when I open my window in the ICU in Nasser Hospital in Khan Yunis, you see the war in front of your eyes. You see the bombs, you feel the bombs, you see the fighter jets, and you see the impact of that. The first thing in the morning and the afternoon that a family has to is to wait for 2 or 3 hours to get clean water. And I tried, you can see these jars of water. These are very heavy. One time I was walking and a woman was holding 2 of them, and I wanted to help her. And I carried one of them for 5 minutes, and my neck was hurting for the next 2 days. So these are really heavy ones, but every day a family has to go and collect clean water to their children and to their family. And then you have to wait for 2 hours to get bread because there's only few bakeries that are open, waiting for bread. Can you tell me what's the observation from the last video? Women and children, what else? They're waiting in line. So despite of the war and the shortage, people are very organized. Sometimes you expect chaos, you expect people fighting for the bread, but people are very patient. And I could not explain this phenomena except for the fact that people are very resilient and also the power of faith. They have patience and they have faith in the future and faith in their community. This is the clinic that we established 2 days before we arrived. And I went the first day, I'm a pulmonologist, and I wanted to see, I went to my clinic there, and I expected to see maybe 50 patients. So the first day we had 700 patients. 700 patients. And I did not know how we saw all of these patients, but these are people who are displaced, who did not have access to healthcare. We provide them with counseling, with medications, with few labs. This is one of the patients, Abdul Karim. He's 15 years old. His mom told me that he used to carry 2 big jars of water every morning, and now he's not able to carry even one, and he lost 15 kilograms, and he had jaundice. So I diagnosed him with hepatitis A. We did not have proper labs to confirm the diagnosis, but there was an outbreak of hepatitis A at that time because of the lack of clean water. And this is Alma. And this is what you see in the mass casualty event, after the mass casualty event. I'm going to show you some of the videos that may be a little bit graphic, so if you don't want to see them, close your eyes. This is the clinic, of course. This is one of the mass casualty events that happened in Nasser Hospital after a missile hit a distribution center near the hospital. So I was leaving the hospital, the emergency room, then I started to see people coming to the hospital. Some of them carried on their shoulders, some of them on ambulances, and then we did not have enough beds in the emergency room, so we resuscitated the patients in the floor of the emergency room. This is Dr. Thair Ahmad trying to intubate a patient. His name is Muhammad Khalil Abu Shahla. He's 12 years old. He was in the distribution unit when it was hit. He had shrapnels on his brain and shrapnels in his belly, and he was unconscious. So Dr. Thair was trying to intubate him on the floor of the and local doctors were using portable ultrasound. This is something that I felt that our mission was accomplished. Building resiliency in communities that are prone to disasters is through training, through adaptable technology, through staying with these communities for long term, through sustainable healthcare programs, training the trainers. And they are able to serve their community more than us coming from the West or the US. And this is Muhammad Khalil Abu Shahla in the next day in the ICU. He was intubated, he had brain injury because of shrapnels, he had also abdominal injuries, he went to the OR, he had surgery, he never woke up. So we pronounced him brain dead in the morning. I took a picture of his death certificate to show it to the media and to our policy makers. I showed it to my senator and also to President Biden. I met with him in April of this year, and also Vice President Harris was in the meeting. I showed them the picture of Muhammad Khalil Abu Shahla, and I told them the story, and I told them that there are many children like Muhammad Khalil that were killed and injured in Gaza. And I thought that they will move to action because we called for ceasefire, we called for increasing humanitarian assistance, and things that our government can do, but they did not do it for the reasons that we know. And you see the bombs and the displacement every day. I'm going to ask you what this picture represents for people who know the history. Have you seen pictures of 1948 displacement? Okay, 1948, 1948. These are actually pictures from 2024. I took them myself. And you can see the resemblance between what you expect to see in 1948 and 2024. Not much changed. They called it at that time a Nakba, the catastrophe. This is a Nakba unfolding in front of our eyes every day. We have pictures, we have videos, we have the whole media, international media, and the outcome is the same. And
تطلع بالمستقبل شو اسمك؟ شو حابب تطلع بالمستقبل؟ دكتور إن شاء الله. بأي صف؟
Anyone understand Arabic? So this is a child, I saw him in the hospital, his name is Abdullah, and I asked him, what would you like to be in the future? And what did he say? Doctor. Every child I ask in Gaza, what would you like to be in the future? He said, a doctor. Gaza has one of the highest literacy rate in the region, by the way, because of the work of UNRWA and other UN agencies and NGOs, and people all have very high expectation of health. The healthcare system in Gaza was very developed before this crisis. One of the hospitals called Al-Shifa Hospital, a tertiary center that was right now destroyed, has been in existence for 76 years before the establishment of the State of Israel. And it's a huge tertiary center, better than the center that I practice in Chicago. They have the best technology, the best doctors. The doctors in Gaza are better than the doctors in the US because they're up to date and they want to serve their community. They're hungry for knowledge. And this system is being dismantled every day. And at the same time, people have adapted to the situation. So you go to the street, you see children playing. You go to the beach. This is the Mediterranean Sea, and you have children, playing children. They want to live also. And people are smiling. They make jokes. They invite you to drink a cup of tea, even with their limited resources. And you tell them, okay, this is happening, and you have war and stuff like that, and they say, "Adi, that's normal." So this patience and resiliency I haven't seen in any other place. So that's why the people in Gaza and the people in Yemen, the people in Syria, the people in Bangladesh, Sudan deserve our attention. And I think it's responsibility for us who have abundance of things, especially freedom, and the ability to speak, is to speak on behalf of the population that we serve. And the video that we'll show at the end is basically advocacy on behalf of the people that we serve. Thank you very much. Jazakallah.
I'd like to thank Dr. Sahloul for his presentation. It was very moving. I also want to take a moment to put in a short plug for the Med Global conferences that take place in Chicago. I was honored to attend the conference over the last 2 years, and I think it is a great opportunity to learn more about all the great things that Med Global is doing, and also to learn how to be active. They spend time not only presenting what they do, but also teaching us how to do more. And so I want to thank Dr. Sahloul for that as well. Do we have time for questions? Who's the moderator here? We'll take a moment, Dr. Sahloul, if you don't mind, if anyone has any questions.
Thank you for your presentation. I have no words to say. We're very grateful that you are here and you're opening our eyes. Just one thing I have to say is we are a bunch of physicians and very talented people here, but we don't know how to help in a situation like this with our expertise. So what is one thing that you can teach us today that we can take back home and be helpful?
I was in a situation like this. I'm still practicing physician. I'm a full-time practicing physician. This is all volunteer work. I believe I pushed myself when the crisis started in my homeland in Syria to learn certain skills, to start organize medical missions, to see what is better to help the local population. So I think each one of you can do a lot of things. So the first thing is to pay attention. And I liked really the talk of Brother Youssef, because I think paying attention to racism, to health inequities, to why a child in Gaza or in Syria or in Yemen or in Sudan dying because they don't have access to oral hydration fluid, to Gatorade. And we are still celebrating the abundance of things that we have. We are very privileged communities. I'm talking about the Muslim communities in the United States. And I believe that this is a test for us. And if we do not use everything that we have access to, our skills, the ability to organize, the freedom to travel with the American passport everywhere, the ability to volunteer in organizations like MediGlobal, donations, planned giving, all of this will help populations. I think this is the main responsibility that we have as a community of faith. So I invite you to, of course, join MediGlobal. You can donate to any programs. You can volunteer. We have a volunteer page. And of course, volunteer is limited. We cannot take them. We have 3,000 people who want to go to Gaza, physicians. But if you have certain skills that are needed, if you're able to take 4 weeks out of your time to spend in Gaza, or if you want to go to Syria, we just had a team that returned from Syria of 8 physicians, or other places. If you can help in telehealth, if you can help in research, if you can help in publishing, if you can represent MediGlobal in advocacy with your Congress, or just raise awareness about these issues to your congressperson or to your senator, I think that would be great. There's plenty of opportunity for everyone to get involved.
Hello, thank you so much for this wonderful presentation. I think I've cried quite a bit with both of your presentations, but crying is not enough. And so helping out what you've mentioned, doing all those things, how do you recommend we convince our family members, our spouses, our family members to let us go, to allow us to go attend these camps?
Yeah, it's not easy. Actually, I give credit to my wife that she pushes me to go to places like this. But at the same time, she wanted to make sure that we have life insurance, which doesn't protect you if you had problems in Gaza. But I think it's important for the whole family to understand the responsibility of us being in the United States, having access to everything, and the ability to help. The initial medical mission could be going to safe areas, relatively, to Mexico, to Colombia, to places like that, to even Yemen. Right now, Yemen is safe compared to a few years ago. And also helping from distance. And gradually you can get to the mode, hopefully with the help of your spouse and the support of your community, to go to disaster areas. But I would suggest to do it gradually.
Dr. Sahloul will be here for lunch, and also at our event at night, correct?
Yes.
Wonderful. So please, yes, and I will show you. And so please do approach him with any other questions or to speak with him offline.
Okay, are we good? Okay. Okay.
So, Colonel Ali Turabi, his military career began when he was accepted into the Uniformed Services University in Bethesda, Maryland. He attended between 2003 and 2007, and he received his doctorate of medicine there. He then went on to complete an anesthesiology fellowship at the Walter Reed Army Medical Center. Upon completion of this residency, he was serving as the trauma anesthesiologist in Germany at their regional medical center in Europe. And he was then sent back to Walter Reed for an interventional pain fellowship. Following this fellowship, he again returned to Germany, where he was serving as the chief of pain management. Colonel Turabi was deployed in support of Operation Enduring Freedom and was assigned as chief anesthesiologist for the 710th Military Company as part of their role in the joint NATO hospital in Kabul, Afghanistan. He served on the Kabul Golden Hour Offset Surgical Team, or the GHOST team. Following this deployment, he was assigned to Magdigan Army Medical Center in Washington State. He then left active duty after 14 years of active Army service, and he joined the United States Reserve in 2019. He was assigned to the 348th Field Hospital in 2020, and he volunteered and completed humanitarian aid missions in Guam and served as medical support officer in charge for jungle survival training in Belize. Most recently, he was deployed to Kuwait in support of Operation Spartan Shield as the Deputy Commander of Clinical Services for the United States Military Hospital in Kuwait. During this deployment, Colonel Turabi was officer in charge for medical and humanitarian care off of the coast of Gaza City on the humanitarian aid pier. He returned from this deployment in June of early this year. He's married to Maria Turabi. He has 3 children, Amatullah, Taha, and Lamia, and he's part of my home Jamaat of Washington, D.C. The following, he asked that I say, and kind of forced me to say that he's my favorite person in the Jamaat. I love him, and I can't imagine my life without him. He's humble and amazing, and it tears me up to say it a little bit. But in all sincerity, I personally feel that it's an honor to call Ali Turabi my friend. So with that, Colonel Ali Turabi.
You're also my favorite person in the Jamaat. I'm an anesthesiologist, so I'm going to try not to put you to sleep. But recently, I had the opportunity to go on this mission to Gaza. There's a humanitarian aid pier, which was set to deliver food and shelters to the people of Palestine. I was sent to Kuwait for 3 months, where we did planning for the mission, and then so I was in Kuwait, there's a big hub army base there. And then around April timeframe, at the end of April, we went and set off to our mission to Gaza. So I'm going to kind of tell my story here. These views do not represent the views of the United States government. These are my views. These are my pictures that I've taken, and I have a consulting job as well. So there's some learning objectives. I just want people to kind of gain some interest into humanitarian aid care and what we can offer. Just like Dr. Sahloul said, we have opportunity with so many brilliant people, so many brilliant minds here to change, kind of make some difference and make some changes throughout the world. And so I want everyone to kind of think of that, what they can do. And just following on with Dr. or Yusuf Zakir's presentation, there is some cultural and linguistic competency and implicit bias that we have, and that's definitely there with the U.S. Army, which is, basically I was the only Muslim person in that whole group, the only Indian person, the only Muslim person, probably there was some Latinos, some black people, but other than that, it was mainly a white population. Just a little bit, Dr. Manasawala kind of talked about my background, but basically it's all a military background. This picture in the middle is, I took this picture with Mollah's photo in the background, and this is off the coast of Gaza. So, and before I forget, dua che ke Palestine nawaste peace mile. So we had a 3-phased plan. The plan was to do airdrops, ground transportation through Saudi Arabia, Jordan, and Israel, and then the Trident Pier. The pier is known as the Trident Pier, and the mission was known as Operation Neptune Solace. So Cyprus was the primary location. Oops. And just to orient you for the geography, the drive from Kuwait to Gaza, not including the time in the border, was 20 hours and 25 minutes. So it's a big distance to travel, and we had to take that route. They had to take that route. So that was part of the plan. sending pallets of food on through this humanitarian corridor. And then the flight was around 2 hours and 20 minutes. And that flight was from Kuwait City, or around Kuwait City, into Gaza, where we did the airdrops of food. 1,800 kilometers away and 1,100 miles away from where we were in Kuwait. This is again to orient you. Dr. Sahloul talked about the size of Gaza is very small here, and also to show you Cyprus. Cyprus is where we had the hub for where we had all the pallets of food and the warehouses of food, and they boarded the ships in Cyprus, and then they came down, and our pier was right here, right outside of Gaza City. And again, just to orient you, this is the population. The reason the Gaza City was chosen was because the population was the highest, and there was a beach there that was amenable to allow for the Trident Pier to be established there. And then again, just to show you, it's a very small kind of enclave there. So the first thing that we started initially around April was the airdrops, and we organized the airdrops from Kuwait City. So basically pallets of food were loaded onto the planes, large planes, and then they were dropped over Gaza City by parachute. This is the safest for the soldiers and for the Americans, because basically they don't have to go into the area at all. They just drop the pallets, and also they flew at an altitude that was basically not going to be hit by any missiles or other objects. It was the fastest as far as, again, you saw the map, it was 2 hours and 20 minutes by flight versus the other corridors, which were not as fast. It was also the least effective and the most costly. It only provided around 38,000 meals daily, and I'll put that into perspective when we show you the other slides there. But Richard Gowan says the humanitarian workers always complain that airdrops are good photo opportunities, but a lousy way to deliver aid. And then initially we had a really kind of a couple of bad outcomes where the food fell on people, the pallets fell on people, and there were some deaths. So that really wasn't the purpose of what we were trying to do. The ground was fraught with difficulties too, as you saw the pictures that Dr. Sahloul showed. So the border crossing into Israel was just very difficult to get through, even as this was an American group. You saw the pictures of the trucks. Even for the Americans, the searches and seizures of those pallets was extremely onerous, and the average time to get through the border was around 10 hours. So that's on top of the 20-hour drive that you had to do. There's 37.5 million tons of conflict-generated debris in Gaza, and 3.2 is attributed to road damage. The roads are horrible, and so driving these big trucks of pallets of food is also very difficult. The debris is laced with unexploded ordnance, so 10% of the bombs that have fallen there have not exploded. So you could just be driving and hit a bomb, right? So that's also very dangerous. And then they did an estimate that with full impact of cleaning, it would take 14 years to clean that debris. And then the other issues we had hijacking of trucks along through the border, hijacking of and security of the drivers. The drivers were mainly Jordanians. Once we got through Jordan, they're American soldiers. Once we got into a certain area, then the drivers were Jordanians, and they had problems getting through. So this leads me to what we thought was a very good idea, and it had all kinds of problems as well, which I'm going to talk about. But the hub here in Cyprus was where we had the warehouses full of pallets. People would multiple countries would bring their pallets there. They would get loaded onto a boat. The boat was 247 miles, and it was 17 hours by boat. This is where I got on to the boat from Cyprus. I went to Cyprus and then got on the boats, and then there was these huge boats full of pallets of food that were loaded onto the boats, and then they were taken to a floating pier, which was 5 miles off the coast of Gaza. So this is a term that we call stabbing the beach, which was phase one of the operation. Basically, the pieces of the pieces of the pier are different types of pieces which fit together like Lego pieces, and because there's no stability along the water, the only stable point is when it stabs into the beach. So you have to find a suitable area. You have to have very good weather. You have to have very low waves to allow for that stabbing of the beach. So that portion was like the most important part of the whole mission, because without us stabbing the beach, we wouldn't have had a stable pier. So again, the sea state, which is like the waves, if the waves were too high, we had to delay. The security was an issue because we were threatened by Hamas, that they would attack us, and then also Israel basically didn't want us there either, so we had lots of roadblocks from them. And then we were told that at one point that they wouldn't go into Rafah, but then they did go into Rafah, the Israelis went into Rafah, and then that created delays for us as well for getting the pier stabbed. So once we got there, there was about 2 to 3 weeks of delay before we could actually stab the pier, because it was such a important part that we had to have like very good conditions to stab the pier. There was a 2-day weapons stoppage from the U.S., only 2 days it lasted, but that stoppage of weapons from the U.S. to Israel delayed us, because then Israel wouldn't let us move in that space either. So a lot of political ramifications of getting the pier established initially. So this is a bird's eye view of the pier, and just to give you, a frame of reference, basically the boats would come right here. They would unload onto trucks, and the trucks would drive down the pier, and they would go to a warehouse, which was, they were unloaded, and NGOs would distribute the food there. The U.S. military was not authorized to get onto the beach or touch the ground at all. So, so basically, the area here, I was located on the area here on the pier at the front. It was right around this area here was our medical boat. So we had a medical boat which had a resuscitation team, which was there to basically support the mission. This is a video, so obviously we know that this is a very unsafe area, but I took this video, and the pictures are limited because we weren't really supposed to be taking many pictures, and also it was kind of dangerous. But I'm going to play this video just to give you an idea. This is a video that I took. So this is a live firefight. I was maybe 200 yards from a live firefight going on with huge machine guns, huge guns. I could see it at night. We could see bombs going off. We could hear it, just like Dr. Sahloul said. You could feel it. I could, for like a month after I came back, I still heard bombs going off. It was crazy. And so, this is a very active war zone. It's a very dangerous combat zone. So this is the floating pier. So there's a pier that's 5 miles out from the actual main pier that we saw. And the reason for that is because these big, huge ships, they're too big to get all the way down close to the pier. So we had to unload the pallets onto smaller ships at this floating pier, which is about 5 miles out. So a lot of logistics and a lot of moving pieces were involved. So this floating pier had to be set up as well, along with the other pier that I showed you, which was along the beachhead. Aid pallets, so these are what the aid pallets kind of look like here. This is from UAE, and then there was all different countries that were involved in providing us aid, so it wasn't just US. United Kingdom, France, UAE, Germany, Egypt I highlighted because they provided the most amount of pallets, which was 14,000 pallets. In the pallets were sustainable food items, high-energy biscuits. Kenya provided shelters, so tents, and then Jordan also provided quite a bit, and obviously the U.S. provided some aid. We were able to successfully get aid to Gaza. beyond the problems that we had. And I'll talk about, what other problems we had, but basically we were successfully able to get some food into Gaza. And it was actually quite a bit of food, and I'll talk about that here. This is a picture I also took here of Gaza, so you can see this is Gaza City. Every single building is just destroyed. It's in reality it's just a very bad situation. So the pier was initially supposed to operate for 90 days, but because of all the issues that we talked about, it only operated for 20 days. There was the main thing was the waves, which kind of broke the pier at one point. Again, all kinds of other problems as well, but we fell short of the goal. The goal was to provide 500,000 or more pallets of food for 3 months. Instead, we delivered aid to feed 450,000 for 1 month. It was the largest humanitarian aid mission done by the U.S. Army, so we had never done a humanitarian aid mission into an active combat zone, which was a first. And also, this pier has never been used for humanitarian aid work. It was always used for like combat operations or things like that. And really, the last time it was used was in World War II, even. So it was like it hasn't really been used actively for this purpose. And then we did provide nearly 20 million pounds of food to humanitarian organizations on ground in Gaza. So again, lots of obstacles. Foreign governments, mainly Israel, was one of the biggest obstacle that we had. The Israeli government. Hazardous conditions. So this picture I show is we had to get from this boat onto this smaller boat every day when we went to basically 5 miles over to the pier. One of our doctors fell in the water and went under the ship, and we thought we had lost him, but we were able to pull him out. This right here, this brown thing I'm wearing, is a pressure. It's a flotation device that activates by pressure. So like once you go in the water, it blows up really fast if the pressure's too high, and it pops you back up. And that's the only thing that saved his life, that he had one of those on. And then briefly, I'm just going to talk about, I don't have much time, but the actual medical part of it. The main purpose of the mission was to provide food, and this was kind of a side quest, a side item thing that we were allowed to do. And just to show you, this was our medical boat that we had initially. So lots of just random stuff back here. This space was 14 feet by 14 feet, extremely small. So we had to plan for that. We couldn't bring too much equipment or too many people because this was the only space that we had. We were able to utilize the space. And this was the beginning product. We had basically just the back of a ship with a bunch of garbage on it. And then this was the end product. We had 2 trauma bays. We had fluids. We had a Belmont rapid transfuser to give blood very quickly, 10 units of blood. We had the ability to support 2 severe trauma cases, oxygen, wound care. We were able to do damage control, resuscitation, and we could evacuate to higher levels of care. Initially, we were supposed to have a surgical team, but there just wasn't enough space to do surgery there, so it was more of a resuscitation team. We had 2 ventilators, we had a bunch of anesthetic drugs, and then we had airway support equipment. This was my medical team. I was the officer in charge, and then we had 2 ER docs, 1 anesthesiologist, 1 physician's assistant, 5 medics, 2 nurses, 1 peds nurse, and 1 ER nurse. So this is the last slide. This is just to show you kind of what the pallets look like. They're very heavy, require a forklift and all that. And this was when we were there, just taking pictures. You can see smoke and bombs going off. Any questions?
Any questions for Colonel Turabi here? All right, very good. I think we have one question over here.
Ali, hey. This is not a fair question for you, but thinking about, you've been there, you've seen it, and now with the new administration. When do you see this ending?
If I had the answer to that question, that's a very difficult question to answer. I think this is, I think you touched on this, and Dr. Sahloul touched on this. This is a much bigger problem, right? And so I think, this is not going to be something that's solved overnight, for sure, right? We need a ceasefire, 100%. I think everybody agrees on that, especially in this room. We need a ceasefire. We need it as quickly as possible. But we also need this to stop happening ever again in the future, right? And so how do we do that? And the way I think about my position and my job is like, I didn't start out a colonel. We have to get involved much more. And I think everyone's been touching on this. We have to be involved. We have to try to change the way this is working, because this is not acceptable,
Can I ask a question? Once it does, and once the hostilities end, how long do you think it is for you and Dr. Sahloul? How long would it take Gaza to recover to any degree of because you mentioned how Gaza City.
Yeah. So the question was, how long will it take them to recover once this stops? So again, the study was 14 years just to clean the debris. That's with a full court press, right? So that's a very difficult question to answer. If they have resources, if they have lots of resources, then it could be done in 14 years, but they don't have those resources. If you look at the pictures, the other picture I showed, Gaza City is probably the biggest city, and it's every single I was like shocked, because I was in Afghanistan, in Kabul, which is also a big city, and it was a functioning city. It was in war, but not every single building. There was a couple of buildings destroyed here and there, but this is every single building destroyed. This is like scorched earth. There's nothing left. So this is not something that's going to be cleaned up very quickly at all. I would be shocked if it was 14 years if the ceasefire happened right now.
Dr. Sahloul, I think, also had a comment about that, yeah.
I think sister may have, but my comment is a kind of reflection. My son also is in the Navy, and how do you deal with the pressure from multiple areas on your mental health? My son at one point was thinking of resigning. He works in the government also. I convinced him not to, because I believe in service, and you can serve your community and your country any place that you go. So how do you deal with this, external pressure on your mental health and your family to continue to serve?
That's a good question. I'm still figuring that piece out. I think having the community has helped me a lot, and I think my wife was very supportive when I said I'm going to Gaza. So she was extremely supportive, and my mom, I think she's here. She just a quick note. My mom didn't think I was going to graduate high school, so. Can you stand up, Mummy? Mummy, stand up. Puto. Can we give her a round of applause?
I think we have one question.
I don't know how to answer the question. Sorry. Go ahead.
No. I think we have one question over here. We have time, I think, for one last question here.
Make sure she gets her chance.
Okay.
Hi, thank you. I think it was along similar lines, but my question was more, have you faced, and I'm sure you have, but the dilemma of maybe, morally, how you feel about what the U.S. Army is doing and then being a part of it. And even with the idea of this mission being about aid, the background knowledge of actually the U.S. Army is so involved in causing the problem in the first place. Like, how have you dealt with that moral dilemma, if at all?
Well, that's a difficult question to answer, because the U.S. Army hasn't really, we've sent weapons there, but the U.S. Army hasn't done anything as far as going to war. This is a global problem with the U.S. government politics, right? So the U.S. Army is a tool that we use to defend the country, right? So if I just resigned and I say, oh, I don't want to be a part of this organization, then I don't think that this mission would have been possible either, right? Because I was also part of pushing for this mission. So we have so many resources in the US Army and other big organizations. If we are lopsided and we say, oh, I don't want to be part of it, then that organization is not going to do what it could do.
Right. One last question here. I think that Colonel Turabi, I think, will be joining us for lunch also if you have any other offline questions.
Thank you, Dr. Turabi, and for also the service that you do for our country and for us to be able to be here today. I just wanted to bring up a kind of a story that I also, Dr. John Keller was also part of a conference that I was privileged of being able to put together at the American Academy of Pediatrics, where he described a situation where there's airdrops of food that not clear to me who was dropping the food, but then video cameras being taken of the hordes of people, of course, if they've been starving, coming in, taking that food and dispersing in a way that they were describing on social media as ants do. If you have some piece of, a dana of nashta that's like, a chawal that's there. So 2 questions. One is, how do you, seeing, even within your group, stand up for those that, other people might be opposed to being described as inhumane? And question number 2 is slightly unrelated, but what does the Army do, what does the military do to support you as a person of diversity within that situation?
So the second question I think is easier to answer because things have changed over the years, and it was very difficult in the beginning, especially like I had to get special permission for Dari, and when nobody had a Dari, it was like very strange for people, and they just hadn't seen it before. But now I'm just the guy with the beard, right? So like it's over time, people's perceptions change. They see me, they talk to me, they know I'm a regular person, and so they, the other side can sometimes demonize, Muslims, right? So like, how do we change that perception? And somebody, you have to reach out to the aisle, just like I think Dr. Sahloul and Yusuf said sometimes, and that I think has changed, and it still needs to change some. But I think they have supported me in that. And then the other thing is like, why would they not want me, right? Like I speak Urdu, I speak Gujarati, I speak Hindi, right? I have some Arabic knowledge. They need me too, right? So I think they've realized that as well, and I think that's improved things. And then the first question, I forgot what you were saying.
How do you address the dehumanization that you see maybe amongst people, just amongst chatter, amongst your group or other groups that you work with in the military?
Yeah, I mean, I think it's, you have to speak up. I mean, you have to, if there's some, and also, it's funny because you may hear it on the side, but they may not say it in front of me because they know clearly I'm Muslim, right? But then you still have to speak up, right? Like you're hearing it. And that was, I think, one of the things I had part of my team was like, we had a very diverse group of people, but there was no Muslims and there was no brown people, right? So it was diversity, but like only white people, right? So if you insert yourself a little bit and just like you said, make yourself uncomfortable, then I think things will eventually change, but it's a slow process.
Thank you so much, Dr. Turabi. One thing that struck me about both of these talks was the difference that one person can make when they apply themselves, when they're willing to make themselves uncomfortable and put themselves in those situations. We think of the U.S. Army as this monolithic enterprise, and yet you had so much influence on this mission and on perceptions both within and without. So thank you both for that wonderful talk. I'd like to take a moment to just go ahead.